the tissue spaces and the capillary wall will form the barriers to absorption. If you give a drug subcutaneously, then the adipose tissue will be a barrier to absorption, and again the capillary wall will also be. So barrier to absorption, anything that gets between where you put the drug and where you want the drug to go, and for systemic absorption, the place you always want the drug to go is in the plasma. Another factor to take into account is conditions at the site. Now, does it make sense that the degree to which a drug will be absorbed depends on the perfusion of the area and the rate at which the drug will be absorbed? So, for example, in the subcutaneous tissue, it's not as well perfused as the muscle tissue, so the drug is absorbed more slowly because of the degree of perfusion. Now, when people are hot, they're well perfused. So if you give a subcutaneous injection when people are hot, it will be absorbed more quickly. This is important, for example, in people that are taking insulin. If they've just had a hot bath, the insulin will work more quickly and it might drop their blood sugars fairly quickly, resulting in a hypoglycemia. Or if you look at the converse situation, when people are very cold or when people are shocked and are peripherally shut down, if drugs are given subcutaneously in hypothermia or shock, they won't be absorbed because there's no circulation to the surface of the body. So the circulation affects the degree to which the drug is absorbed. Another factor that's worth bearing in mind is the idea of first pass metabolism. It's quite an important principle in pharmacology. First pass metabolism. Now, it's the liver that breaks down most drugs. So when the blood goes through the liver, some of the drug is broken down by the liver. But if a drug is taken orally and is absorbed through the wall of the stomach, that drug will go into the hepatic portal vein. And the hepatic portal vein will take all of that blood to the liver. And because the drug is going from the stomach to the hepatic portal vein to the liver, it means the concentrations of the drug which arrive at the liver are high. And very often a lot of that drug is broken down in the liver the first time the blood goes through the liver, the first pass of the blood through the liver. Whereas if you give drugs via a parenteral route, for example intramuscularly or intravenously, when the blood gets back to the liver in the normal circulation, the drug is already diluted in the blood, and less of that drug proportionally will be broken down by the liver. So various factors which influence drug action. Barriers to absorption, anything between where you put the drug and the plasma. Conditions at the site of administration, for example if the patient is hot, cold or shocked. Factors affecting distribution related to the circulation. Another factor here is that the amount of fat that an individual has. So if a drug is water soluble, you might get higher concentrations in female organs than in male organs, because females have more fatty tissue than men on average. Or of course if people were obese, then again you would get a higher concentration in the water soluble tissues than in the fat soluble tissues, a higher concentration in the organs than in the fatty tissue. So the relative amount of adipose tissue in the body can make a difference. Other factors affecting tissue concentration, we mentioned perfusion. And there's a couple other points to mention here. Some drugs go into the brain very poorly because there's a blood-brain barrier between the brain and the blood. There's a physiological barrier which keeps out toxins, and sometimes that keeps out drugs as well. And another tissue where drugs are sometimes poorly absorbed into, particularly antibiotics, is the bone. So you can have quite high plasma levels of antibiotic in the blood, but virtually no antibiotic in the bone. This is one reason that osteomyelitis can be so difficult to treat. First pass metabolism, for example, nitrates are nearly all metabolized if you take them orally. And beta blockers, about 90% of beta blockers about 90% of the given dose of a beta blocker can be metabolized the first time that blood passes through the liver. That's why the parenteral dose of beta blockers is often, well, is much lower than the oral dose. The next concept I want to think about is that of protein binding. Protein binding. Now, when drugs are in the plasma, they usually bind to the protein that's in the plasma. Typically, it's the albumin that's in the plasma. And this is important to know about because when a drug is protein bound, when it's bound onto the plasma albumin, it's inactive. It's only the drug which is free that is active. And there is an equilibrium between the amount of free drug and the amount of protein bound drug. And some drugs are more protein bound than others. And it's important to know about this because if the amount of albumin is reduced in the body, then the amount of protein binding will also be reduced. So for example, in the elderly they tend to have less albumin. In some liver disorders there's less albumin. In malnutrition there'd be less albumin. And if there's less albumin, that means there is less protein binding. If there's less protein binding, it means there's more of the free form of the drug. That means that a given dose of the drug will have a greater effect. Now, the next principle of pharmacology we're going to discuss is that of drug metabolism. It's what happens to the drug after it's entered the body. Now, biotransformation refers to the metabolizing of a drug down into smaller molecules which are easier to excrete. So the body breaks drugs down so it can excrete them. Depends on the drug, of course. Some drugs are excreted almost unchanged, but most are broken down first. And it's primarily the liver that's important in this catabolic process. Catabolism means a metabolic process involved in breaking things down. So it's the liver primarily which breaks drug molecules down into simpler molecules which can then be excreted via the kidneys. But enzymes for breaking drugs down are also found in the gut, in the lungs and in the kidneys and blood. But it's the liver that does most of the catabolism, the breaking down, the metabolizing of drugs so they can be excreted. So drugs are broken down primarily by the liver and excreted primarily by the kidneys in the urine. But drugs are also excreted into the bile via the liver, into the biliary tracts and into the gastrointestinal tract. Some drugs may therefore be excreted via the bowel. Some drugs are excreted via the lungs to an extent. They're breathed out. So if someone's been drinking, you can smell the alcohol on the breath. That's because the drug is being excreted to a degree via the lungs. And also drugs can be excreted via the exocrine glands sometimes. So for example, the sweat glands. So when some drugs you can actually smell it in the patient's sweat as it's excreted. But normally it's the liver and the kidneys that are primarily involved. The liver breaking the drug down and the kidney excreting it in the urine. And this brings us on to a very important concept in pharmacology, the idea of half-life. Now, half-life is the time it takes for half of the given dose to be excreted from the body. Half of the given dose to be eliminated from the plasma, really. So you give 100 milligrams of drug, and in 1 hour's time there's only 50 milligrams left, then the half-life of that drug would be 1 hour. Some drugs have a half-life of seconds or minutes. Others have a half-life of hours. Some drugs can even have a half-life of days or even weeks. And this is quite important to know because if a drug's got a short half-life, you need to give the doses fairly frequently to maintain the plasma levels of the drug. If the drug's got a long half-life, then you need to give the drug infrequently, you give it less frequently. Let's look at a graphical representation of the idea of half-life, this important concept of the duration of action of the drug. So, when a drug is given, the plasma concentrations will rise. for example if it's given via an injection, but you get rise in plasma concentrations. And at one point you get a peak plasma concentration. So here we have a peak plasma concentration of 100 units of the drug. But then, as the drug is broken down via the liver and excreted via the kidneys, the plasma concentration of that drug will start to drop. Now, when that plasma concentration has dropped to half of the initial concentration, then we describe that as the half-life of the drug. So this would be time, this is concentration on this axis here, plasma concentration. It's time on this axis here. So this time here, taken to eliminate half of the absorbed dose of the drug, is the half-life of that drug. So if that time is 1 hour, the half-life of that drug is 1 hour. If that time is 10 hours, the half-life of that drug is 10 hours. But let's suppose that's taken an hour to eliminate half the given dose of the drug. Now, can you see now that there's 50 units of the drug left? So to eliminate the next half, to get down to only 25 units left, is going to take the same amount of time again. It's going to take the half-life again. So it took that amount of time to get from 100 to 50, and to halve the amount of drug that's in the blood again will take that amount of time again. So if the half-life is an hour, it takes another hour to get down to 25% of the original highest concentration, that is 50% of that concentration. Now you've got 25 units of drug left in the blood. Now again, to halve this again, it's going to take another hour, given an hour is the half-life of that drug. So that's going to go down to about there, because it takes the same amount of time again to eliminate half the plasma concentration. So we've now got, that was 50 units left, that was 25 left, we're now down to 12.5 units left. Now to halve the amount of drug again is going to take the half-life again. It's going to take another hour if half-life is the time. So we're now into that situation. Then to halve that would take the half-life again. So what you find with plasma concentrations of a drug is it rises, and every half-life, half of the given dose is excreted, then half again, then half again, and half again. So here we're looking at the red line, which describes the plasma concentration of the drug under consideration, demonstrating the principle of the half-life of the drug. So that's the concept of half-life of a drug. Now, with some drugs, the limiting factor is the rate at which the liver can break down the drug. So as the plasma concentrations of some drugs rise, it's easy for more drug to be excreted in the urine. So with many drugs, the higher the amount of drug in the plasma, the more rapidly it can be excreted. But if the drug must first be broken down by liver cells, by the enzymes in liver cells, then there are a limited amount of liver cells available in the body. Obviously, the liver is of a limited size. So this means there's a limited amount of work it can do in any given hour. So drugs which are primarily hepatically metabolized are excreted in a slightly different way. And this is what we're going to look at now. A very good example of this is alcohol. When people drink alcohol, the alcohol is broken down by the liver cells, by the dehydrogenase enzymes in the liver. But there's only a limited number of liver cells, so there's a limited rate at which the alcohol can be broken down. And roughly, alcohol is broken down at the rate of 1 unit of alcohol per hour. And you probably remember that 1 unit of alcohol is equal to 10 mils of pure ethanol. 10 mils of pure ethanol. Not 10 mils of alcoholic drink, but 10 mils of the ethanol that's in it. So for example, if someone drank 100 mils of wine, the wine was 10% alcohol, then 100 mils, that would represent 10 mils of ethanol, because 10 is 10% of 100. So that would be 1 unit of alcohol. And to excrete 1 unit of alcohol takes about 1 hour. So for example, a pint of beer, 500-600 mils of beer, is about 2 units of alcohol, depending of course on the strength of the beer. It can be much more with stronger beer. So if someone drinks 4 pints of beer, it would take them about 8 hours to excrete the alcohol, because that is 8 units of alcohol. So let's look at the way drugs which must be hepatically metabolized before excretion are eliminated from the body. So let's draw a graph again. Let's suppose that this axis represents the plasma concentration. And this axis represents time. Now suppose someone drinks, I've put some markers on here, let's have 1 hour, 2 hours, 3 hours, 4 hours, 5 hours, 6 hours, 7 hours. Suppose someone drinks 10 units of alcohol. So that's 1, 2, 3, 4, 5, 6, 8. No, I've only got space for 9. So this is units of alcohol. This is time in hours. Suppose someone drinks 9 units of alcohol. Then initially, if they drink it quickly, that will rise to 9 units of alcohol being in the body. So that's the initial concentration. But because the alcohol must be broken down by the liver, and this can only be done at a limited rate, then after an hour, another hour, the liver will only have been able to break down 1 unit of alcohol. So there'll be 8 units left. Because it's the ability of the liver to metabolize the drug which is the limiting factor in this sort of excretion. After 3 hours, another unit will have been eliminated, so we're down to 7 units. After 4 hours, we're down to 6. After 5 hours, we're down to 5. After 6 hours, we're down to 4. After 7 hours, we're down to 3. So even 7 hours after the person has stopped drinking, there's still 3 units of alcohol in their blood. And that is enough, certainly, to interfere with activities such as driving. So this is the pattern of excretion for drugs which are dependent on hepatic metabolism for their excretion. A slightly different pattern to the more common pattern of half-life that we have just previously described. So we've mentioned that enzymes are essential for breaking down drugs, any drug that is not excreted unaltered from the body. And most of these enzymes are found in the liver, although we have mentioned other places like the gut and the blood where they're found. And this is the same with all biochemistry in the body. It depends on enzymes. Biochemical reactions are facilitated, if you like, catalyzed by biological enzymes. And enzymes are biological catalysts. A catalyst is anything which facilitates a chemical reaction, but does not take place in that reaction itself. And in the same way, for biochemical transformation to take place, there must be enzymic action. So let's imagine there is substance A in the body. That must be broken down into substance B, and maybe substance B is broken down into substances C and D for excretion. Very often, the breakdown products of a drug are pharmacologically less active than the initial product, although that is not always the case. Now, A will not be converted to B unless it's acted on by an enzyme to facilitate the reaction. And let's call that enzyme A. Enzyme A is the biological catalyst present normally in liver cells that facilitates that reaction. For B to be broken down into C, you need enzyme B. And for this to happen, for B to be converted into D, we need another enzyme, let's call it enzyme C. So specific enzymes breaking down specific biological molecules. Enzymic action taking place largely in the biochemical factory of the body. The biochemical factory of the body is the liver. So we've talked quite a bit about drug metabolism and how drugs are excreted. Let's just think of a few applications of this before we pass on to the next section. Now, it's necessary to have adequate plasma concentrations of a drug in the plasma to achieve therapeutic concentrations. There's a therapeutic range. So for a particular drug, you're aiming for a particular concentration in the plasma. If the plasma concentration falls below that level, it'll be below the therapeutic range, and there won't be enough drug in the plasma to have the therapeutic effect you want the drug to have. Conversely, if the amount of drug in the plasma rises too high, then you can start getting toxic effects from that drug. So the aim is to keep the drug within a therapeutic range. And we normally do this by adjusting the time intervals over which we give the dose. Drugs with short half-lives will need to be given more frequently. Drugs with longer half-lives might need to be given less frequently. Some drugs, of course, can be kept in very accurate plasma concentration ranges by giving intravenous infusions. The next idea that this brings along is the idea of loading dose. Now, to achieve a therapeutic plasma concentration, you might need to give several routine doses of a drug to get the concentration up to that. However, an alternative way of doing this sometimes is to give an initially larger dose to rapidly achieve therapeutic plasma concentrations. An initially larger dose to rapidly achieve therapeutic plasma concentrations. So, for example, when we're heparinizing someone, we'll give them 5,000 international units of heparin as an IV bolus injection, followed up by, say, 20,000 units of heparin over a longer period of time by infusion. So sometimes the loading dose is appropriate, because the alternative is waiting for quite a long time before you get the therapeutic effect. And if the patient's very ill, they need the therapeutic effect earlier. Now, another idea I want to introduce now is the fact that drugs often go across the placenta into the mother and can adversely affect the developing fetus, the developing baby. So always find out if your patients are pregnant. If they are, ask someone who is experienced in this area if that drug will do the child any harm. If the drug will do the developing child harm, then you need to think again about what you're doing. Sometimes it may be necessary to take a risk in this area, but that's a clinical judgment that needs to be taken by a fairly experienced person. Another implication is breastfeeding. Actually, when a mother is breastfeeding, the drugs that are in her blood can be incorporated into the breast milk. And most drugs, actually, to some degree, are incorporated into breast milk. So what this means is the drug that the mother is getting, the baby is also getting some of. And that often needs to be taken into consideration. Alcohol, for example, is excreted in breast milk. So if the mother drinks alcohol, the baby will be given alcohol, which clearly you don't want to happen. So bear in mind the effects on unborn children during pregnancy and young children during breastfeeding. Finally, let's think about the elderly, which we'll look at in detail as a separate section in a little while. But it's worth remembering at this stage that the elderly normally excrete drugs more slowly than younger people. So they have a longer acting effect and often a greater consequent pharmacological effect in older people. In children, of course, where the body mass is small, smaller amounts of drug need to be given. Because remember, we calculate the dose of drug by milligrams of drug per kilogram of the patient's body weight. Now, at the start of this programme, we mentioned that drugs can be dangerous. And it's important to remember there is always an element of risk whenever you give a drug. You can never say that giving any drug is risk-free. There's just varying degrees of risk. We've talked about side effects, we've talked about toxic effects, but drugs can give rise to adverse reactions, adverse drug reactions. And basically, there's two types of drug reactions and drug adverse reactions. These are referred to as type 1 and type 2. Type 1 reactions, first of all. Type 1 reactions depend on the dose of drug that's given. The higher the dose of drug, the greater the adverse effect is likely to be. And as well as that, the type 1 adverse reactions are predictable. They're predictable because you can work it out from the pharmacology of that drug. So, for example, giving non-steroidal anti-inflammatory drugs is likely to give rise to gastric symptoms because of the effect it has on the lining of the stomach, reducing the blood supply to the lining of the stomach, increasing the concentration of hydrochloric acid, and it can give rise to acute gastric and peptic ulceration. That's predictable. It's known that NSAIDs, non-steroidal anti-inflammatory drugs, do these things. Beta blockers block the beta sympathetic nervous system receptors. Therefore, it's possible to work out that they can cause bronchospasm and exacerbate conditions such as chronic obstructive airways disease and asthma. So type 1 adverse reactions, predictable, dose dependent, you can work it out depending on the pharmacology. However, the type 2 reactions are unpredictable and they are not dose dependent. So, for example, there could be an allergic reaction to a drug. Allergies are potentially life-threatening. Now, very often allergic reactions can be things like rashes, itchiness, pruritus, itchiness, urticaria, like the wheals can develop on the surface of the body. Another common one is rhinitis, irritation of the nose and sneezing, allergic reactions. But allergic reactions can also be life-threatening. These are the anaphylactic type reactions. So sometimes a drug can be given and almost instantly, or within a few minutes of giving the drug, the patient can have a severe life-threatening reaction to this drug. And it's not dose dependent. It can happen with very, very small amounts of the drug. For example, patients can be allergic to iodine, antibiotics, non-steroidal anti-inflammatory drugs. Patients can be allergic to drugs containing starch if they're given intravenously. There's a whole range of things that patients can be allergic to. Antibiotics are probably the most common one that you might come across. But any drug potentially, really a patient can be allergic to. Some patients are predisposed to this because they are atopic. They make immunoglobulin type E's readily in response to everyday substances. they may already be suffering from some other allergic conditions such as asthma or eczema. But there again, this may not be the case. Anaphylactic reactions can occur in patients who have no previous history of allergy. It can just occur out of the blue with no warning. So always bear in mind the possibility of anaphylactic reactions. This means patients need to be observed by you as a professional for some time after the drug has been given. Now, we've dealt with anaphylaxis in detail on another video, but for now let's notice that there are several potential life-threatening things to look for. Anaphylaxis is anaphylactic shock, so the patient becomes very shocked. But because the shock is often caused by a peripheral vasodilation, initially the patient goes red and not white. So the patient may go red, or the patient may lose the blood pressure. They may go red and lose the blood pressure, or they may just lose the blood pressure. Become acutely hypotensive. That, of course, is life-threatening. The blood pressure is very low, the brain will not be perfused, the myocardium will not be perfused. The patient will be acutely shocked, and that requires emergency management. Another dangerous feature is that it can cause bronchospasm. The bronchioles can close down, and that means the patient can't breathe. The patient can asphyxiate. Another life-threatening feature is the development of edema round about the mouth and round about the airway. Acute swelling round about the larynx or the upper airway. And that can obstruct the upper airway and cause a complete blockage and asphyxia. So anaphylactic reactions should always be observed for after drugs have been given. They normally occur quickly if they're going to occur. With parenterally administered drugs, injections, they can occur within seconds. Sometimes with orally administered drugs, the effect can be delayed for several minutes. If the reaction does occur, then the patient needs to be given something like intravenous Piriton, intravenous steroids, hydrocortisone, for example, could be given, or sometimes intramuscular adrenaline or subcutaneous adrenaline is required, depending on the severity of the reaction. Of course, adrenaline is a dangerous thing to give in itself because it can stimulate the myocardium and cause ectopic heartbeats and abnormalities of cardiac rhythm. So be very careful when you do give adrenaline, if you do give it, and only give it if it's a very serious situation. As well as that, if you can, give the patient 100% oxygen to keep the myocardium well oxygenated. So although anaphylactic reactions are incredibly rare, if they do occur, you need to recognise it, treat it promptly, because they are life-threatening conditions. Rare, very rare. Most healthcare professionals might only see an anaphylactic reaction every few years, every 10 years or so. But very important to know about if you are giving drugs, because you could save the patient's life if the reaction occurs. Now, another term that's sometimes heard is iatrogenic. Iatros means doctor, genic, beginning of. So these are iatrogenic disorders, describe disorders caused by any medical intervention, any medical treatment. So I suppose you could say that adverse reactions, type 1 and type 2, are both examples of iatrogenic reactions. And the last term I want to talk about in this section is teratogenic. Something which is teratogenic will abnormally affect fetal development. The particularly important time is during the first 12 weeks of fetal development, when shape is being formed, the process of morphogenesis. So always be careful with drugs during pregnancy, or indeed if there's a risk of pregnancy, if a woman doesn't know whether she's pregnant or not, it's often best to assume, or safest to assume, that in fact she is, until she has a menstrual period or a pregnancy test and is proved not to be pregnant. So bear in mind the possibility of iatrogenic effects. When people are on drugs, it's important you take this into account in your understanding of the whole clinical picture that is presented, because sometimes the clinical features can be drug-induced and not due to some disease process. Let's just have a look at a few possible clinical symptoms, signs that you might come across in the clinical area, and see if you can think about what drug may give rise to the particular symptom. List of clinical features. Can you think of any drugs that could cause these?